guys. So I know that you guys have done acid-base imbalances and you took your quiz, and your test should be this next week for chronic kidney disease and everything you've covered so far. So this one's going to be about chronic kidney disease. Again, if you have any questions, Robin, myself, but mainly Robin's your go-to. So chronic kidney disease, progressive and irreversible. So when you have acute kidney disease, it is reversible. As long as you take care of the cause, you can restore kidney function with acute, but with chronic, it's irreversible. So you can't recover with it, and once it cannot sustain life, then it turns into end-stage kidney disease. So an example of like acute would be like stones, trauma, infection, myocardial infarction, because it's not getting enough perfusion. But if you fix that cause, then you can restore kidney function. The main cause of chronic kidney disease is diabetes, because you're having constant high amounts of sugar that's causing damage to your kidneys, or hypertension because of all the high pressure. Those are the two main causes of chronic kidney disease. So review of what the kidneys do. Look at your renin-aldosterone angiotensin system. But this on her PowerPoint here, this is super helpful. I know that you guys had a really long chart before that we took a couple times over in SLA, and it took a lot to kind of memorize, but this one's very easy to understand. So regulatory, your kidney functions regulate fluids, electrolytes. It sees all of your blood. Your kidneys are probably your number one perfused organ. Acid-base imbalances. It filters wastes, so it eliminates all of your toxins in your body. So glomerular, never noticed how I say that. Filtration, and then tubular reabsorption. So it'll all kind of like filter out, and then you'll reabsorb like potassium, water, stuff like that, electrolytes, and then you'll secrete everything you don't need. So hormonal regulation, look at your renin. So renin is released when you have a decreased blood pressure or volume. So renin is released when you have decreased BP. Then that causes your production of angiotensin II. Angiotensin II is a vasoconstrictor. So renin is released when you have decreased BP. Then once you have a decreased BP, that also stimulates angiotensin II, which is a vasoconstrictor. So it's trying to stimulate any kind of blood that you do have back up to your heart. Release of aldosterone, and then we know aldosterone reabsorbs your sodium, and then water follows sodium. So when you have a low BP, renin is going to be released. Renin is released when decreased amount of blood volume. Then that causes the production of angiotensin II. Angiotensin II is a vasoconstrictor. And then once it vasoconstricts, that releases your aldosterone. Aldosterone reabsorbs sodium, which in results reabsorbs water. That way you're increasing the amount of volume you do have, plus you're constricting it to make it go back to the vital organs. So increased water absorption, increased volume, and BP. So hopefully that made a little bit of sense. Renin is released when you have a decreased BP. It also releases angiotensin II because that's a vasoconstrictor, trying to get all the blood that you have left back to the vital organs. Then once you're vasoconstricting, you're also going to release your aldosterone, which reabsorbs sodium, and sodium also reabsorbs water. So you're increasing your amount from constricting back to the vital organs, and you're also increasing the volume by increasing sodium and water reabsorption. Prostaglandins, and also regulates the filtration. Erythropoietin, I can never pronounce these words. That stimulates your red blood cell production. So when I look at this word, the first part, erythro, tells me that it has to do with my red blood cells. So if you're low in your production, then it's going to produce more. Activates vitamin D because vitamin D helps absorb calcium in the GI tract, and so it tries to regulate that balance as well. So any kidney problem that disrupts the function has systemic effects. So to fluid and electrolytes and your acid-base imbalance. So when you're thinking about your kidneys, they either hold on to stuff. If it's if you don't have enough of it, you're going to hold on to it. But if you have too much, you're going to excrete it. So if there's any kind of damage at all. Sorry, I have a gnat in this house and we're trying to make banana bread. It's not working. All the gnats are still here. Help. But if you have anything wrong with the way that you're excreting or holding on to, if your kidney, which is its main function is to excrete or hold on to, if it's messed up, if it's abnormal, you're going to have fluid and electrolyte imbalances. So kidney disorders that can affect this would be like congenital, if you have like a lot of cysts in your kidneys. Majority of them need transplants. It can be obstructive, infection, carcinoma, trauma, immunologic, so body's immune system attacks its own cells. It's a big word down here. Glomerulonephritis. It's just infection. It's infection. It's a streptococcal infection, but it's just inflammation. Nephrotic syndrome, degenerative, acute, and chronic. So just different disorders that will affect how your kidneys filter. So acute kidney injury, we kind of talked about this already. Rapid decrease in kidney function, but if you catch it early enough and you treat it, your kidneys can regain that function. So etiology on this one part, it has pre-renal, intrarenal, and post-renal. So pre is just anything above the actual kidney. So if it has to do with like your blood flow, cardiac output, hypovolemia. If you're not getting enough blood to your kidneys, they're not going to react right. If you have a shock, if you're hypotensive and tachycardia and shock, you're not getting the perfusion that you need to your kidneys. Decreased cardiac output is decreased perfusion to any vital organ. Anything that's going to affect blood getting to the kidneys is pre-renal. Intrarenal is anything that has to do while it's in the kidney. So shock can also be in this one. I know it's a little confusing. Shock causes hypovolemia, so it can be pre, but once you don't get enough blood into your kidney, it can be like ischemic to that kidney. So shock causes ischemia, so it can also be intra. Transfusion reactions, trauma, medications, because medications are excreted through your kidneys, or chemicals. So like Tylenol, dialysis dialysis is how you treat certain things. Yeah, so just like think of your toxic medications. When you take too much of something, or if your body's not processing it correctly, it can harm your kidneys, in your kidneys, which would be intrarenal. Inflammatory process can also happen in your kidneys. Post-renal is obstruction. So I just think of stones, kidney stones. If you have a kidney stone in your kidney and then it goes through a ureter and it gets stuck before it gets to your bladder, it's post-renal. It's out of your kidney, but it's anywhere underneath your kidney, through your ureter, bladder, or urethra. So clots, stones, tumors, injury that impedes outflow of urine. Okay, so I also have here increased creatinine is acute, and BUN and GFR is chronic. So when you have increased creatinine, your body is telling you that you're not getting rid of it. So you're going to have a lot more of it when your kidney is not working properly. But that's acute. But chronic is BUN and GFR. So just memorize that creatinine is acute, because she will ask that. That's something I have underlined a crap ton in these notes. If it's high creatinine, you're looking at acute kidney injury, not chronic. Leading causes, we talked about this, diabetes and uncontrolled hypertension. So medications, she has a list of here, medications and nephrotoxicities. So just look over these. She won't ask to specifics of this list, but aminoglycosides, Vanco. Vanco is really irritating to a lot of things. If you put it in an IV, it can be really irritating. For kidneys, it's irritating. Radiology contrast, that's really bad for your kidneys. Gram-negative toxins, pesticides. Just look at the list that she gives you. So stages of chronic kidney disease. So for me, the GFR was hard to memorize from 1 to 5. She gives you this chart I would look it over. I wrote over here numbers. So it goes 90, 60, 30, 15, 15. That's how I remember it. So the first one is above 90. So if you're stage 1, you're at risk. Like everyone could probably be at stage 1, but you're at risk, but you're still above that 90 mLs per minute. So it's not like your kidney is not working. You're just more at risk. Then stage 2, you have 60 to 89. And then stage 3 is 30 to 59. Stage 4 is 15 to 29. And stage 5 is below 15. So I wrote down like 90, 60, 30, 15, 15. So just think of like in increments of 30. 90 minus 30 is 60, minus 30 is 30, and then half of 30 is 15 and 15. It's kind of hard to think about it that way, but 60, half of that, or 90 minus 30 is 60, minus 30 is 30. 60 minus 30 is 30, and then half of that is 15, and then anything below 15 is stage 5. Look at what complications and interventions she has on there. She might ask something like, your patient's in stage 4. Why is this cause, like what is causing this to be a stage 4? Just look at like what complications there are, and then look at how to fix whatever stage you're in. Some stages like stage 5 needs a transplant. I mean, they can do, it says without dialysis or transplant that the patient will die. They can do dialysis, but people don't do well on dialysis for very, very long, so they're going to need a transplant eventually. Okay, so diagnostic. So I do have written on here acute. If you can see acute, creatinine, acute. So memorize that. I told you that before, memorize it. So creatinine is 0.6 to 1.2. It's acute. It indicates damage of acute level. It is nitrogenous waste in the muscle metabolism. Just know creatinine, know the normal, 0.6 to 1.2, and it's acute. And BUN is chronic. So BUN is 10 to 20, and it is the end product of protein metabolism. It is formed from ammonia, and ammonia can make, if you have high levels of ammonia, I'm sure most of you know this, but it can cause the patient to be confused. So you give rifampin lactulose. That's like the, I don't want to say antidote to ammonia, but it helps not confuse the patient because you have such high levels of ammonia. But BUN is basically looking at your protein metabolism, and we all know protein and ammonia are linked. So look at your ammonia levels, and if they're high, your patient might be confused. Give your rifampin lactulose. Sensitive to hydration. So this kind of measures like your hypovolemic state. You're going to realize it with BUN. By itself, it is not an accurate indicator of kidney function. So she might ask you like, what is the diagnostic test for chronic? It'll say BUN, but like if you're trying to look at how well your kidney's functioning, BUN is not the only thing you're supposed to look at. And then you can also look at your 24-hour urine creatinine clearance. It also measures your GFR. Those two together, BUN and GFR, is how you'll measure like how well your kidney is working, and those will be high if you're in chronic. Creatinine is high if you're in acute. So changes due to kidney function. So metabolic changes. When your kidney is not working, you're going to increase your amount of creatinine and urea BUN. So you're going to have more buildup of that waste because your kidneys aren't working and you're not able to excrete it. So a buildup from waste, you're going to want a decreased protein diet. If you're in like chronic kidney failure, you're not going to want to take in more protein because then once that protein is broken down, then your BUN is going to go up even more. So for people who have kidney disease issues, you want a decreased protein diet. Acid-base imbalances, so you're not getting rid of your hydrogen ions. You're decrease your amount of acid, reabsorption of bicarb, decreased amount of, decreased amount of acid excretion, so your hydrogen ions, also decreased amount of reabsorption of bicarb, so you're going to have metabolic acidosis. You're not excreting your hydrogen ions, so you have more acid. Also, you're not reabsorbing your bicarb base, which is going to make you even more acidotic. So metabolic acidosis. And people will compensate with increased respirations because they have so much acid they're trying to blow it off. So they'll have those Kussmaul's respirations. That's in a later stage. You won't see it at first because your body's still trying to compensate. But once your body's not, I mean, your respiration wise, you are compensating, but your body is trying to compensate metabolically. So your respirations won't increase until a later stage. So electrolyte changes, so your sodium. So your hyponatremia is in an early stage. So you're going to decrease the amount of healthy neurons to reabsorb that Na. So you're excreting it, but you're not reabsorbing it, so you're low. And then in later stages, everything is not doing well, so you can't even excrete it, so you're going to be hypernatremia. So hypo at first, because your body can excrete it but not reabsorb it, and then hyper, high amounts of sodium later on, because you can't even excrete it or reabsorb. Like if you can't excrete, then you don't even get to the reabsorption phase, but it'll be lower because your kidneys just aren't filtering really anything. So for those people, you're going to want low sodium and potassium diet as well. So these people, you're going to have to call in dietary, because if they're in low protein because of the metabolic changes, and you're not going to want to take in more protein because your BUN is going to increase, and then you're not going to want to take in sodium or potassium because that's all going to increase, you're going to want to call in your nutrition people and see, because most of these people aren't, like most chronic kidney patients are also have hypertension, also have diabetes. Like they're on diets already because they probably have other things going on with them. And then potassium, sorry, I said low potassium. I didn't explain why. So hypercalcemia, K is not excreted, and it will rise quickly to 7 or 8. It is life-threatening. A lot of people think like, oh, well, if I can't have salt, I'll just like have salt substitutes. Salt is Na, sodium, but a lot of the salt substitutes have potassium in it. So you're going to want to not give them any kind of salt with the sodium or salt with the salt substitutes with the potassium, neither. Calcium and phosphorus, they are inversely balanced. So you're going to have low phosphorus excretion. And then she said here, look at your different like PTH and your phosphorus levels in your blood. But just look at what she has on her PowerPoint. As phosphorus levels increase, calcium decreases because they're inversely related. So a decreased amount of calcium stimulates your parathyroid to release PTH. Once your calcium is released from storage in your bones, you're going to decrease your bone density. Crystallize. I think she missed a word, whatever. Formed from excessive calcium binding to phosphorus. So they bind together. So when you have a high amount of one, it's going to bind, and then it's going to show a low amount of phosphorus. It can lodge in the heart. It can lodge in like a blood vessel, joints, eyes, brain. It causes uremic frost because you got that like itchy white skin. Trust me, you'll know if you have seen uremic frost. Just look at that. She won't ask too much about it, but she might ask a question or two. Decreased amount of calcium releases PTH. Calcium is also released from So decreased amount of calcium in your body will stimulate the parathyroid glands to release more PTH because you want to produce more calcium and hold on to more calcium. Also, calcium will be released from the bones because that's where it's stored. So if you're pulling stuff out of your bones are going to become decreased in density. And then it can form crystals once it binds with phosphorus, and they can lodge different places. Hematologic. So anemia, impaired platelet function, erythropoietin is going to be excreted because you want to produce more red blood cells. Iron supplements, you can take iron supplements because you're anemic. Cardiac functioning is, so if you have cardiac issues already, you're not going to get the perfusion to your kidneys you need. But also, if your kidneys are decreased and they're not reabsorbing water, then you're going to become hypovolemic. So kidneys and heart always go hand in hand, no matter what. If your heart's not working, it's not perfusing your kidneys. If your kidneys aren't fusing and they're not reabsorbing, they're not giving your heart anything to pump. They go hand in hand. So results of chronic kidney disease can be fluid retention because you're not getting rid of anything, or in the early stages, if you're getting rid of stuff and not reabsorbing it, you'll be hypotensive. Dysfunction of the renin, angiotensin, aldosterone system, heart failure because of fluid overload. So in the early stages, your kidneys aren't able to reabsorb. They can excrete like everything. You're going to be low in everything. And then you're going to have a decreased amount of reabsorption. So it's going to be hypovolemic. But then as your kidney disease progresses and then it becomes chronic kidney disease or later stages, you're not able to get rid of anything. So then you're going to become like hypervolemic. I don't really know if that's a word, but increased amount of fluid, cardiac or heart failure can happen because you just fluid overload. GI, so uremia, like we said before. So halitosis is a sweet smelling breath. It's because you have an increased amount of ammonia. And then ammonia can also, anorexia, vomiting, nausea, vomiting, hiccups. Interesting. And then ulcers can form. And then you can have GI bleeds because you have ulcers. Okay, terminology. So just memorize your terminology. She'll use it. You're going to want to know it. Azotemia is nitrogenous. Oh my God, I'm so sorry. Nitrogenous waste products build up. So azotemia. Oh, I thought there's an N in that word. Azotemia is nitrogenous waste buildup. Uremia is azotemia with clinical symptoms. That's where that was. So azotemia is increase in nitrogenous wastes. Uremia is the same thing with clinical symptoms. It says see chart. I'd see the chart. And then uremic frost is that layer on like the skin that becomes itchy and it smells like sweet. It says due to evaporated sweat, but any kind of like ammonia has like a sweet smell, like on your breath, it smells really sweet. And then your skin gets really itchy. And then just know your oleuria, which is less than 400 milliliters of urine in 24 hours. So their kidneys aren't producing much urine at all. And then anuria, which is less than 100. So oleuria, I guess I never pronounced the G. Anyway, is less than 400, and then anuria is less than 100. So if you think of the A, it's really like you're supposed to produce like 30 mLs an hour. If you're producing less than 124, your kidneys aren't working. Also, I just have written down, you can have a metallic taste, kind of like what we said on the other slide, anorexia, nausea, vomiting, muscle cramps, irritability, fatigue, dyspnea, and then she has another slide here for like fluid and electrolyte imbalances, acid-base imbalances, buildup of nitrogenous and uremic wastes. So, and then she gives you another chart here. I'd look that up too. So this chart and that chart. And then she gives you a list of your different like systems, organ systems. And then she wants you to say like, if you were having kidney issues, what would it cause all of these other symptoms or systems? So neurologically, you'd have a decreased level of conscious. So not only are you having heart failure, so you're not getting blood where you need to. You're having heart failure because you have kidney failure, because when one fails, the other fails. And so in relation, your heart is not pumping to your brain as effectively, so you're going to have a decreased level of consciousness. Also, I can't think of the word. Oh, come on. I just had it. We've talked about it this whole time. Starts with an A. Starts with an A. Come on, Maddie. Uremia. I know uremic frost from, it's not anemia, it's like the same kind of, I don't know, I can't think of this word. Why can't I think of this word? It can make your patient really confused. Ammonia. Ammonia. So to start over, if your kidneys aren't working, they're not getting your perfusion back to your heart very well, so your heart's going to fail. So you have kidney failure, heart failure, they go together. So because your heart's failing, you're not going to produce or perfuse your kidneys you're not going to perfuse blood from your heart to your brain very well. So you're going to be decreased level of consciousness, but also you're also going to have that like ammonia effect, because a lot of ammonia can decrease your level of consciousness. Cardiac, we just talked about. Respiratory, we talked about earlier. If it's like a late stage of kidney failure, kidney failure, you're going to be in metabolic acidosis. So your heart's going to, or your lungs are going to try and compensate. So you're going to have increased respirations. And then we talked about most of these before. Skeletal, you're going to pull out that calcium. Urinary, it's all about your kidneys. You're not either excreting or you're not excreting or you're not reabsorbing, depending on late or early stage. Skin can become itchy. Halidosis from like a sweet smelling breath of ammonia. GI, you can have like different ulcers that come up. So management, delaying the process. So if you know that your kidneys aren't functioning correctly, what can you do to stop it from getting worse quicker? You can manage your fluid volume. You can always give, if they're losing too much because they're not reabsorbing, give them fluids. If they're not being able to excrete anything, then you can give them like your, oh, come on. Why can't I think of words today? Starts with an F? No. Something to make them pee a lot. Get rid of all the extra fluid. I don't know why I can't think of the word. I'll think of the word. But if they're not excreting anything and they have fluid overload, you can, what's it called? I know you are looking at me like, I'll think of it in a minute, but you can make them pee it out. Lasix, loop diuretics. You can give them a diuretic. Manage electrolytes, see where their levels are. If they're high, if they're low, do they need some? Do they need to get rid of some? Can we put them on dialysis? Dialysis is a couple slides before or after this one. Prevent electrolyte imbalances, treat acidosis. So you can always like try and give them, treat the cause. So yeah, that's all I'm going to say for that. Control diabetes, improve cardiac output, prevent injury, prevent infections, watch nutritional status. So like we said before, limit protein intake. We said that earlier. Limit fluid intake, because when they're in chronic kidney failure, they're going to be fluid overloaded. So you're going to want to decrease the fluid intake and give them diuretics. Restrict sodium, potassium, and phosphorus because they're not excreting it, so they're going to have high levels. Take minerals and vitamin supplements because your bones are taking stuff out to try and compensate, so you don't have any buildup left. So you're going to want to take some like mineral vitamin supplements. Eating enough calories to meet metabolic needs. So because you're decreasing all of this stuff that they can have, make sure they're still getting the calories that they need. Maybe they're on TPN because they have to have a certain mixture cocktail of whatever they're supposed to have. Avoid salt substitutes because they're high in potassium. And avoid magnesium because it's in like antacids. Okay, so drug therapies, diuretics. It's on this page. I'm so smart. Diuretics, so results in the loss of K, and because you have hyperkalemia and you're also fluid overload, so decrease your fluid by giving diuretics. Phosphate binders. So we talked about phosphate and calcium. They are inversely related, and then they also bind to each other. So calcium or carbonate, you can take it with meds because you're going to have a high level of phosphate. So you're going to want to give calcium because they're going to bind, and then they're going to bring both of those levels in your system down. It's going to decrease those. May cause constipation. Don't take within 2 hours of other scheduled meds though, because they bind, it'll also have adverse reactions. Alkaline replacement to counteract acidosis. Minerals, vitamin D, because that will suppress your PTH production and then the secretion to treat the hypocalcemia. So if you give vitamin D, it decreases your secretion, and then that'll also help with your hypocalcemia. Why can't I say that word? I just said it 5 minutes ago. Erythropoietin. That's going to stimulate your red blood cells to be produced, which is in your bone marrow, and then your BP medication to control the fluid overload, and then Kayactylase. It binds and increases potassium. So, it binds to decrease potassium because potassium's high. So when you have a high potassium, you give this, and that'll make your potassium lower. But she won't ask any. I can't remember any questions about that one. Considerations. So use antibiotics and nephrotoxic drugs sparingly. So the things that can harm your kidneys, you're going to want to decrease the amount of the stuff that you use for that. Any meds that can be metabolized in the kidneys need to be adjusted for their doses. So if it's going to be metabolized in the kidneys and your kidneys aren't functioning, you're going to want to give a lower dose. Because if you give a higher dose and it's not going to be metabolized and excreted out, then you're going to have a high amount of that drug still circulating. Watch the half-life, risk of toxicity, and then digoxin toxicity is one that is metabolized in the kidneys. So if you give too much of digoxin, you're going to be toxic because the half-life is still going to be in your circulatory system. Watch for halovision for that digoxin toxic halovision or altered vision in general. Monitor changes. Okay. Dialysis. So there's RRT, renal replacement therapy. So when a patient no longer can manage with different therapies, they use this. So hemodialysis is the most common form. They have like peritoneal dialysis, and we'll talk about it. But hemodialysis is the most common. So they can put in like dialysis catheters. They usually put them in like either subclavian or jugular. Don't use femoral because it's going to cause so many infections. But hemodialysis, where they can remove the excess fluid and the waste products from your blood. They can also restore chemical and electrolyte imbalances. So it goes into a machine, and the machine, it kind of acts like your kidneys, and it removes all the excess fluid and all your wastes, but also you can put stuff in as well. Many patients survive many years on this, but some only survive a few months. So it just depends on how progressive their kidney disease is. Are they on the transplant list? Are they likely to get a transplant? Can they survive with dialysis? So patient's blood passes through a semi-permeable membrane and performs the filtering excretion, and then diffusion movements of the particles increase the concentration of the area and decrease the concentration. So it just, like I said before, it goes into a machine. It can be filtered out. Things can be added in, and then it goes back into your bloodstream. 4 hours is usually the treatment, and it can be over 3 times a week. Heparin is also infused into the blood. So whenever you're taking blood out and putting blood back in, there's a risk that clots are going to develop. So they put heparin in there. She just shows you a picture of a circuit and how, I mean, some people have like dialysis catheters like tunneled, also in like their wrists, but most common is, I mean, when I see them in like ICUs, they're up here, in order for it to work. So she does talk about AV fistula, arterial venous fistula, or an AV graft. So these, I know like nursing considerations, don't take BPs or blood draws on that arm. Make sure you have signs up. It can be I think that's somewhere in here. Yeah, she has on the next page. So long-term hernia can be AV fistulas. You take the artery and the vein, and it lasts longer, less clotting, less infection. AV graft is tunneled. artificial vessels underneath the skin is connected to the patient's own artery and vein, and then they are cuffed and tunneled catheters. Temporary access can be hemodialysis catheters, may be temporarily placed in the subclavian until that AV fistula matures. So AV fistula is one that's like long-term, and it takes, I can't remember time, months to mature because the skin still has to like grow around it. But temporarily you can put like a subclavian one. Oh, Mom, you need out. Erica, you can move. You can crawl. I love her. Okay. And then never take blood pressure or blood draws or start an IV on that arm with the AV fistula or graft. Complications can be like clots, infections, aneurysms, ischemia. And so same thing underneath dialysis care. Many drugs are diazable. I have no idea how to say that word. But when you give a patient a drug and then 15 minutes later they go down for dialysis, it can just be taken out of their system and metabolized without their body metabolizing. It can just be like taken out of their system through their bloodstream. So try and give meds way before dialysis or wait until they come back from dialysis and then give them their medications. Daily weights. So your daily weights is your number one. You're going to want to check your fluid status. No invasive procedures for 4 to 6 hours after dialysis. This is because they put heparin in those lines and they infuse heparin in. So if you do dialysis and then you have an invasive procedure 4 to 6 hours later, they're more likely to bleed. Assess for fistula or graft. So you're going to feel if you can feel any thrills or listen for bruits. Post-dialysis treatment, so watch for hypotension because when you're doing dialysis and you take all that fluid off because they have fluid overload, they may become hypotensive. Headaches, nausea, vomiting, dizziness, or muscle cramping or bleeding because they put heparin in it. Peritoneal dialysis is the exchange of waste fluids or electrolytes from the peritoneal cavity. So this is a rubber catheter that they put in the abdominal cavity. And then they put 1 to 2 liters up top in a bag and it infuses into their abdomen, and then gravity for 3 to 4 hours after takes it out. And it's so they leave the fluid in there for 3 to 4 hours, and then over 20 or 30 minutes they let it drain out. This occurs through diffusion and osmosis, and then it's usually done once or twice a day. Just because I don't want to say it's not as effective. If you do it correctly and you do it once or twice a day, it can be effective, but usually hemodialysis is much more common and you only have to do it 3 times a week. Dialysis contains a buffer to correct acidosis, electrolytes, and dextrose through osmotic agent. Less than 10% of dialysis patients use this. So complications can be peritonitis. It's just inflammation because you're putting 1 to 2 liters in your abdomen and then trying to let it all drain out. Pain, exit site or tunnel infection. So when you put that rubber tube in there, you can have issues. Poor flow. So when you're trying to get 1 to 2 liters in and then trying to get the same, if not the same amount, but more out, it can be hard to try and without pushing on the stomach, just letting gravity do its thing, it can be hard to flow out. Leakage, and then nursing care is take vitals of baseline before and after, take their weights, laboratory tests, continuing to monitor for respiratory distress. So when you're filling your belly up with 1 to 2 liters and leaving it in there for 3 to 4 hours for the osmosis to do its thing and get everything, all the bad stuff out, of course it's going to push on your diaphragm. You're going to be I can't breathe. So respiratory distress or discomfort is a big one. Monitor for the out time of the amount that it takes to flow out, and then observe the outflow pattern of fluid. And then last thing is kidney transplant. So she has a page number here. You can take a look at it, but I know her big thing, I think she's super involved in kidney transplants. I think we wrote down in the beginning, there's over 100,000 people waiting for kidney transplants. So they have candidate selection criteria. They have donors, preoperative care, immunologic studies, surgical team, and operation procedure. So complications of, if I'm a donor, or not, if I'm the receiver, I can reject it. Acute tubular necrosis, you can have clots, you can have renal artery stenosis, immunosuppressive medications, and then psychological. So she really didn't ask anything about transplants, but it's a good idea to look over it. That's all I have for this. There is a case study in the back if you want to look at it. If you have any questions, just let me or Robin know. I hope this was helpful. I'm sorry I couldn't think of the word diuretics. I still can't think of the word, but if you have any questions, let us know. I hope this is helping. If it's not, or if you want me to do something different, or if you want me to add something, just email me, let me know, for those of you who are watching. Thank you.